Welcome to Changing Suits. We're your hosts, Bal
and Taj, discussing the latest news, views, and general life for us Western Asians.
Follow us on Instagram and Facebook, changing_suits, and subscribe so you never miss an episode. Hi, welcome to Changing Suits. My name's Bal.
And my name's Taj.
On today's episode, we wanted to explore a topic that got a lot of interest a few weeks back, and that was alcohol abuse and dependency. So we actually wanted to hear it from another point of view. So today we've got Dr Ram Arora with us, who is a GP in Swindon and has done so much community work. So Raman, could you give us a bit of an introduction about yourself and your history as well, please?
Yeah, hi. Many thanks for having me on the show. Um, I am Ramanjit Singh Arora. I am a GP who specializes in addictions. I did my MBBS from India, from Ahmedabad, Gujarat. My first job, however, was in the UK back in 2003, and I decided to train in the UK. I became a GP in 2009, and then from there onwards, around 2012, I decided to do something different, something that would make me stand out as a GP. So I trained as a GP with special interest in addictions. Now, this is a less salubrious area of medicine, often neglected area of medicine, uh, and um, and and yes, that put me in a niche of a selected few.
I was going to say, so it's a niche and no one else wants to do it. However, Raman, you decided to. What made you so interested in this area specifically?
When I started working in Swindon, that was my first job as a GP. I was looking after the homeless people. Now, Swindon, apparently, the town center of Swindon apparently has a higher amount of homeless people. So, with homelessness goes things such as addictions and alcoholism and mental health, and that sort of generated an interest in me out of empathy in terms of looking at their experiences as to how these patients could best be helped. um, I almost or nearly almost always found myself out of the water, out quite on the edge when dealing with these patients because the medical curriculum provides very minimal training to clinicians. um, and many of these conversations that we end up having with patients who are homeless, who are actually seeking a particular drug, can be quite challenging because, well, we don't want to prescribe them something that they want. um, and it was these difficult, challenging conversations that made me realize, hang on, there is work needed to be done here. What if I specialized in this subject? What if I was able to support these patients? So it all started from there. So around 2012, I started doing a diploma, uh, an RCGP certificate, which is a diploma level certificate in substance misuse, in particular, opiate misuse management.
What is opiate disuse?
Misuse, yes.
So opiate misuse pertains to usage specifically of heroin or morphine derivatives, opiate derivatives. So that includes morphine, all the pharmaceutical prescribed uh, morphine-based drugs such as codeine, tramadol, oxycodone, things like that.
Working with the community that you did, so the homeless community, does it tend to be a higher percentage of people that are opioid misusers, or do you find that other drugs are also involved? So obviously alcohol is going to be one, but is it mainly opioid misuse?
So homelessness could be due to a variety of reasons, mental health being one of the key reasons. Because with mental health comes family breakdowns. Um, in some ways, if you look at addiction, it is sometimes an adaptation to a difficult environment, a difficult life that that person is living. So it's a way of alteration of a person's own experience of what is a challenging circumstance in their life. So, these patients, they try to alter their experience of life by using opiates or alcohol to numb their pain or numb their emotional pain or physical pain, and things like that. But unfortunately, this creates more problem for the patients in the long run.
In this case, can I just ask on that point? Then, do you tend to find that those people tend to, before they're homeless, start having those mental health issues, start abusing these drugs, and then become homeless, or is it the other way around? What's more common?
So what actually happens is that once uh, the mental health issues have started, and usually there's a high incidence of adverse childhood experiences, emotional trauma, physical abuse, sexual abuse in childhood, emotional abuse being the commonest one, neglect. Uh, then around 12 to 15 years of age, there is this move towards the peer group and this introduction to drugs. If you look at a classic history, it is usually towards drugs such as cannabis, and then towards amphetamines, which then sort of diversifies into cocaine by the age of 18 or thereabout. And around the age of 18, or 16 to 18, is when the first hit of heroin happens. Now, heroin is a is not just a drug, it is the most addictive substance known to man. So once it comes on, once you have established a career with heroin, when I call it a career, I mean it, because it basically takes 20 years of your life to fight that addiction. So if you got introduced to opiates at the age of 18 or 20, then the next 20 years of your life, the opiate, getting that next hit, getting that next high, getting that next relief becomes the epicenter of your life. It is what you live for. You wake up withdrawing. You all you do is seek drugs. Whatever you'll ever acquire, be it from benefits, be it from your parents, be it from theft, is lost in that same day. Funding the drugs.
So when you say 20 years, so what happens at the so if you start at 20, for example, and that's your 20 years, at about 40, what are you referring? What then happens then?
So around the age of 40, few things happen. So we live in the UK, where actually the conventional drug users, so conventional class A drug user cohort, is basically aging. So the average age is now approximating 40 of the conventional drug using cohort. So this is the generation which probably started in early 90s, or year 2000, um, and then started using drugs, and has then been stabilized on opiate substitution therapy, which we can talk about later. Drugs such as methadone, etc., which we give them for stabilizing them. Now, around the age of 40, it depends predominantly on what their treatment is. If they're in treatment, then they can very much expect to live a relatively normal lifespan. And there is apparently a nursing home in Canada which is providing methadone to 80-year-olds. So people can actually expect to live a relatively normal life if they enter an opiate substitution therapy program. However, those who become homeless, who are never able to engage in treatment, and for them the life expectancy can be relatively short. So the average life expectancy of a homeless addicted patient would be in the region of 40 to 44.
What is the treatment? What does it involve?
So a treatment the treatment into into addiction is often difficult. There's often a denial initially that there is a problem. Stigma plays a role, but patients do end up taking treatment. Now, in terms of opiate treatment, we're able to get a lot more than, say, in alcohol treatment. In alcohol treatment, only 1 in 10 people actually get into the services. In opiates, it's a lot more than that.
Oh, that's interesting because although I suppose if someone was to say um, that it's a drug, yes, there is a treatment. Whereas alcohol, it's a bit more miscellaneous because it's so widely used. I'm assuming, is that correct to assume
Yeah,
that?
yeah, I think it's very widely used. I think it's very commonly accepted in the society. So and then there's the stigma, the taboo around seeking treatment. So various reasons could be described. Now, in terms of alcohol treatment, the treatment involves working with counselors, going through your past history, working with alcoholic anonymous or various support groups, working with your key workers, uh, working on your own issues, and that takes time. It is hard work. And then some of these patients who are severely dependent will actually get a detox. Now, detox with alcohol is usually a 10 to 12 day process. Now, the amount of work you do before that process will mean whether you relapse or not. So it's not just a detox that, okay, you have an alcohol addiction and I'll give you a detox tomorrow and you'll get better. Well, it doesn't happen that way. You can see that in hospitals, alcohol dependent patients end up having heart attacks. And when they have heart attacks, they'll be in the hospital and they'll be given an inpatient detox and they'll be treated for their heart problems. But what do they do as soon as they come out? Well, the next day they start drinking again. And the
Mm.
thing is that because a lot of hard work around relapse prevention hasn't happened, a lot of mental health issues, a lot of psychological trauma has not been explored, it all comes back and it all forces the person to start drinking again. Now, with heroin, it's although it's a more difficult, more sticky drug, the treatment is your treatment in methadone is almost a game changer. You see, heroin is a short acting drug. It creates a hit. It probably lasts in your system for a couple of hours, and your body actually adapts to it, and you need more and more of it to produce the same hit. Now, what methadone is a long acting form of morphine. It stays in the system for 5 to 7 days, unlike heroin, which creates a sharp peak and it only stays in your system for 2 to 4 hours. So, a typical patient can go through multiple withdrawals when they're using heroin. And what methadone does is it stabilizes them for a period of 5 to 7 days. So they're no longer withdrawing. So then they are freed from this constant seeking of the drug every 2 to 4 hours, and they can go back to being a parent or being a daughter or being a son or being an employee for a business.
Can I just confirm in that case? So methadone is also an opioid as well, but it's obviously a lower form of the heroin, which is why you tend to use that as a treatment. Is that correct?
Absolutely. So it's a longer acting form of morphine,
Okay.
uh, unlike heroin, which is a very short acting, highly potent form of morphine.
In regards to why I'm going to go take you all the way back, so we've sort of hit all sides of it already.
No, that's
But
fine.
in regards to the start, so you said that a lot of patients start off with a mental health issue, which
Yes,
then obviously snowballs.
yes,
Now, when we obviously the podcast is more specific, well, we look at a lot of South Asian um, issues. Now, what we really enjoy is talking about those taboo issues that we always sweep under the carpet and do cause big issues. Now, do you tend to ever come across patients who are in the South from the South Asian community that are having mental health issues that just aren't being spoken about, and that's what's causing this snowball effect?
no, I completely agree with you that there is a huge gap. Remember, I said that only 10% of the people with an alcohol problem will actually go to an alcohol service. Well, in the South Asian population, it's that number is only 1%. That means
Wow,
only
that's
one in
really
100.
small, isn't it?
Well,
Mm.
So 1 in 100 of the South Asian, Indian, or Pakistani, or Sri Lankan, Bangladeshi origin patients will actually seek help and actually go to a local drug and alcohol service to seek help. So the treatment gap, as we call it, is huge.
why are you finding that it's such a low percentage compared to other communities in that case?
But I think, stigma plays a big role. Log kya kahenge, people,
Can I just say, Raman, the number of times that we've heard that line in
yes,
our podcasts, it's ridiculous. That is the one line that comes up literally every single episode, and it's so depressing that it
yes,
comes up. It's such a shame.
Even in this day and age, we
yes,
still worry about what the community's going to say.
yes.
So again, you're saying it's the same issue. What will people say?
Absolutely. So one of the biggest fear of the British Asian Punjabi families, especially, is being talked about behind the back in the community, and that prevents them from actually going forward and actually talking about this issue openly. And when we don't talk about these issues openly, deal with them openly, then we have only but covert means of managing these issues. So, what are the covert means that we use in our families to manage these issues? So, we say, okay, this could be, I'll try to manage my severe dependence to alcoholism with support of my family. Now, uh, now your family will consist of your daughter, uh, your mother, your wife, uh, your and your children, like brothers and sisters. Now, it seems that the a lot of burden of care actually ends up falling on the women in the household.
So why is it that it falls on the women in the family to look after the person that's dependent?
I think this is the culture bit where women are supposed to, suppose if a husband has got an alcohol problem, the wife in the household is somehow uh, and entrusted with the task to take care of him. And even if he has a severe alcohol dependence problem, with which an alcohol management service might actually struggle with, uh, our community actually assumes that that the female, be it a daughter, be it a wife, will be able to take care of the male.
So, coming from obviously you're from a South Asian background yourself, how if a patient was sitting there in front of you and it was that situation, what would your advice be for that family then?
Well, my advice to the family would be to not be held back by stigma and shame, uh, to actually discuss these issues more openly, to actually seek help with local drug and alcohol services, to make, most of these drug and alcohol services actually have a friends and family group, because they know that, addictions often become a family issue.
Mm.
you know uh, they say that there are about 7 million people living in the UK, 10% of population of UK, who are suffering because one of their relatives has an addiction problem.
What happens to the wife that is supporting? How is she coping with it? Does it affect her mental health?
So having somebody in your family who has an addiction problem uh, is quoted as one of the significant causes amongst women when they come to us suffering with anxiety and depression.
Oh, that's interesting, isn't it?
So it seems that that the shame and stigma almost pushes the problem under the carpet, but it doesn't fix the problem. It only leads to further delay in the management of the problem, where the harm caused by the problem actually becomes even more advanced, so much so that it can no longer be hidden under the carpet. And thus, it actually increases the suffering for many years for patients and their families. It leads to a snowball effect in terms of losses. Most of addiction is almost, isolating. People who have an alcohol problem will have a worsening of their mental health, in particular their anxiety issues. That anxiety will manifest in worsening of their anger issues. What will anger do? Anger would be a poison for their relationships and will cause relationship breakdown, broken families, and eventually, problems at work. So the person finds themselves homeless, possibly divorced, uh, end of the line, and doesn't know where to seek help, and they find themselves isolated culturally, socially, in every possible way.
Just with the fact that obviously you're a GP that specializes in this area, do you tend to find that patients therefore come at a later stage, even to you, even if the community doesn't know about it? Do people come to you slightly earlier?
So what I find is that the people tend to present late, and they
Okay.
tend to present late because denial amongst heavy drinkers Now, this is regardless of ethnicity,
Mm.
is a major problem. So most people will, especially those who are severely dependent, will actually understate the amount of alcohol that they are drinking. uh, they will tell you, okay, that I'm drinking, say, a bottle of wine a day, when the truth might be that it's 3 bottles of wine at night. They might say, okay, I'll probably have a quarter of a bottle of vodka a day, where the truth might be that it's a full bottle of vodka a day. So yeah, so understating the truth is a very common feature. People, essentially, regardless of ethnicity, people don't want to be seen in a bad light.
That's interesting that you said that, because one of the other things that as we've been doing the podcast is also showing the things that we're very similar on. Um, we're human beings.
It's true.
We will have very similar ways of reacting, which is obviously what you're saying.
Absolutely. Absolutely.
And how would you convince that patient? Okay, fine. In your head, there's a light bulb going off saying, oh, this person's obviously more dependent than they're making out. How would then you would how would you then react and sort of advise so that they really become more aware of their own problem? Because that is the main issue, isn't it? Their own awareness.
So, when a patient initially presents to a drug and alcohol service, they're very
Mm.
anxious. They've probably been forced initially 5 or 6 times by their own parents or family, or a significant other to come in, and they're in denial that they actually have a problem. Uh, Eventually, they come to a phase of acceptance from denial because the losses are too many.
Mm.
Uh, when they come to us initially and they still understate their problem, it's a case of them not feeling safe enough to share the problem. Because you can only share the most vulnerable part of you when you're comfortable, when you're comfortable enough with the clinician, when that bond has been built. So that's only when you'll actually share these issues more deeply. But when you do, one of the easiest ways of actually getting the truth out is actually, well, just saying, okay, let's reflect on the fact. Okay, obviously you're in a better place now, you say that, but let's go back 6 months ago, um, and and tell me, say, around 6 months ago, when you were drinking really heavily, how much were you drinking then? And then the truth comes out, because suddenly there's a dissociation from you of today to the you of the past, say, 6 months
Ah,
ago.
Mm.
And and we know that once you have developed that dependence, it's very difficult to break that dependence. So they will then say, okay, well, actually, 6 months ago, gosh, I was drinking a liter of vodka daily. And then you can automatically, once they've said that out of their mouth, and they have realized that the doctor hasn't necessarily reacted in any way, the doctor hasn't become surprised, and he hasn't necessarily judged them in any way, uh, they take a step back. And then when you actually go back with the question, then, that do you think even now there might be days that you might be drinking the same amount? And then they come
So
back and say, yes.
you're almost counselling someone, aren't you? You are
Absolutely.
counselling them to come
Absolutely.
out with everything. Well,
this is
Absolutely.
the tricks and trades of a GP. There we are. Now we're going to have a patient thinking,
Yes.
"Oh, I have to be careful about this."
how much awareness is there in the South Asian community, if at all, um,
So
to
awareness
support
is a
people?
major issue, both in terms of recognizing how much is too much, what is actually a unit of alcohol, how much
Mm.
if I were to drink would classify as hazardous drinking or harmful drinking. And then there's the second lack of awareness, which is when things go wrong, where to actually seek help. So when they did a poll recently, only 7% of the South Asian population knew that that they could actually go to a local drug and alcohol service and seek help. So
I was going to say, I mean, in regards to local services, one of the other things with across the board is if we don't see people like us at those services, it's
yeah,
another barrier, isn't it? Would
I
I go
agree.
back the second time?
I agree. I would completely agree that there is a need, a fundamental need to for services to design themselves on a model to reflect the majority of the population that they are treating. So that would mean that coming up with culturally sensitive ideas of managing it in the Punjabi South Asian community, you know, some of the models that have been developed at some places are quite striking. Uh, so if you look at some of the drug and alcohol services towards Birmingham, they actually have employed uh, first or second generation South Asian Punjabi speaking key workers and peer mentors, who can speak fluent Punjabi, language being one of the key barriers, but then also, you know, about sensitively approaching the issue. If stigma is what causes what prevents people from seeking help, then should confidentiality while seeking help be stressed? you know Similarly, in Sikhism, we obviously, one of the key principles in Sikhism is to avoid all alcohol. However, uh, culturally, if you look at a picture of Sikh masculinity, our culture is almost at par with the religion, where where being a masculine
Associated.
Sikh,
Yeah. Yeah. Yeah.
involves drinking a bit of alcohol, almost a rites of passage, especially in our wedding ceremonies and things like that.
Just going back in regards to the community, sorry, the services should reflect the community they serve. Now, you're based in Swindon, which has relatively quite a low population of South Asians,
Yeah.
but it is increasing. I mean, been looking at the stats in Swindon, and it is, we've got a census analysis coming out quite soon as well.
Mhm.
It did, between the last census, I was reading that the population of South Asians, especially Indians, went up threefold,
Yeah.
but the services aren't keeping up. What
Yes.
would you then advise the strategists further up for a place like Swindon?
So, I think we need to take the message further into the communities. So, during the recent Vaisakhi Velas, in fact, for the last 2 to 3 years, in the last few Vaisakhi Melas that we've been doing, we've been actually speaking with the local drug and alcohol service, and their van actually shows up every time. And some of the members of the local community have sought help and actually benefited from it. Uh, so I think we need to start having an open discussion about it within our own communities. Uh, it is debatable whether the Sikh temples themselves, as they have been in Southall, etc., where they actually run an active, alcohol-related program within the Sikh temples, can play a key role. Uh, and then there are pros and cons to both those elements. The pros being obviously that the temple might provide a sanctuary, and people can, many of the Sikhs actually, or many of the Punjabis would actually uh, go back to spirituality. In fact, South Asians prefer to go back to their own religion, their own spirituality, rather than a 12-step program. So place of worship could of course play a key role in these things. But then again, we have to also offset that against the fact that you might actually have potentially people under the influence visiting a place of worship, which then again doesn't sit well with the rest of the community. So again, something, an in between program somewhere could be developed, and I think things like that have developed in other places in the UK. um, I think we need to also uh, go back to these drug and alcohol services locally and actually facilitate them in running more of these outreach programs. So an outreach program is a program which a local drug and alcohol service or any medical service will run to go into more harder to reach communities. So it could be, a turning point van showing up in say a local Diwali festival or a Baisakhi festival, you know um, as they do in music festivals.
But the problem is, especially when we are so overstretched with the NHS, how likely is that, especially in a place like Swindon, where there is a very low South Asian population? How likely is that would happen?
Well, uh, I think drug and alcohol services. It's no secret to them that only 1% of the South Asian community is engaging. So the treatment gap is huge. So it's actually in their interest as well to actually reach into this community. We recognize that the Black and Asian ethnic minority communities are less likely to engage with the services, and that also then drives through health inequalities. So actually, uh, the these services are also being incentivized to reach these, difficult to reach communities.
Are there women that are coming to the service as well? Because these days, more and more women are drinking as well. Is that the case that women from the South Asian community are seeking help as well?
Yes. So initially, it used to be a men's territory, and actually, Punjabi women drinking was almost frowned upon. Uh, but lately, these trends are changing. As you know, we are more absorbing ourselves. Getting more acculturized into the native population that we live in. We are finding that actually the alcohol intake amongst women in general, and that's a trend even seen in the UK in general, is increasing. Now, that creates its own challenges. A female with addiction is almost a family problem right at the outset, because there are so many variables that get affected. If they have children, child protection services, child social services, etc., care needs, emotional neglect of the child, all those things start coming up. Partners, coercive partners, who's actually getting what out of asking the female to drink. Is this a codependent relationship? Is she in an abusive relationship? Is she drinking because of the relationship? What is actually causing her to do that? And then uh, you know all the other consequences,
It is
social.
it's like a web, isn't it? It's very hard to dissociate any part of this from each other, I guess.
I agree, and I think women are more likely to suffer from the harm from alcohol at a lower dose, because alcohol circulates in the female body for a longer duration of time. So the female organs are more likely to actually be affected. So if you look at, things such as breast cancer, colon cancer, things like that. Well, alcohol is linked as one of the key causes. So alcohol causes 7 different types of cancer. A fact that's almost swept under the carpet in the society. So yeah, so that needs to be talked about too.
Is there currently anything in Swindon specifically that is happening to help the South Asian community to look at this misuse and even raise awareness of it?
I think we as GPs are more switched on now to actually pick this up, and we are more likely to refer patients to the local drug and alcohol service. Um, the drug and alcohol services post COVID have actually become easier to access, because you no longer have to knock at a door now. You can actually fill up an online form on the Turning Point's website, say for Swindon, and get yourself referred in. Uh, and once you do that, you will get contacted by a key worker, care coordinator, and you'll have an initial interview with a key worker, where things such as confidentiality will be discussed, and then you're within the treatment. I think there is an increasing awareness that that there should be more representation in terms of the South Asian community in the working force. Um, uh, and I think and I think most of these drug and alcohol services run equality and diversity training. Uh, so they are sending out more culturally sensitive messages, and they're adapting to the patient populations that are accessing them.
And is there any other area from your research that you think that places like Swindon and a lot of other places, to be fair, should be following and that are making really strong strides in treatments for, and I suppose, community cohesion for alcohol and opioid dependencies?
Well, I think the message for all communities is to actually not push this issue under the carpet, but to actually discuss this more openly, more actively, bring it to the fore, remove that stigma, uh, actually encourage local services that are more culturally sensitive to the target population, provide access, have outreach programs to reach into these more difficult to reach places, as we've seen in places such as South Hall, and also to look at empowering families, so family therapies, so actually creating more family based therapy models maybe also be helpful. So because it's not just the one person that is actually struggling here, it's the whole family that's struggling here. So involving family into the treatment plan.
Interesting that you would say Southall, because we see a lot of people that have come over from various countries and are living on the streets.
Mhm.
And again, depending on alcohol or other drug use.
Sorry, Taj, there was a program years ago that I remember, because there's always that stigma to anyone that's come from, whether it's India, Pakistan, or any of the South Asian communities, who is homeless. It's a case of the reason they're homeless is because they're on these dependent things. However, the program really shifted it in my mind, because I remember they said something like they become homeless, and to be able to survive in that community, because you feel cold, it's a horrible environment, they then start drinking and take the drugs. It's actually the other way around, and that completely changed my view of the whole thing, just from that little bit of that segment
That's
from that
true.
program a few years ago.
That's true. I think the stresses that are faced by the first generation immigrant are very different to what the stresses are for the second generation immigrant. So first generation immigrant is trying to fit in, it is trying to come to terms. They have left their what was a cohesive society in Punjab, and they have moved to a more individualist society here in the UK, which is a very modern way of thinking. So we have gone from a collective society thinking, based thinking, to suddenly, that's whole support around that collective circle is now suddenly lost, and now you're very much on your own, and now you have to cope with this new society that you've suddenly been transplanted in. So that's the dilemma of the first generation, you know and how they cope with it. And I believe.
Do you find that because the first generation for us, for example, was obviously our parents, has
Mhm.
that first generation problem changed from the people that are coming over now, who are pretty much in a similar situation, first generation in this country, then for their families?
I think these are two different countries. I think India still, especially the people coming from the villages of India, and also deeper Punjabi, more traditional Punjabi towns, they still have a very different way of living and a different way of thinking than the West. So yes, there's always that cultural shock, and uh, you know I think immigration amplifies many of the problems, be it mental health problem, be it isolation. All those things get a bit more amplified in the process of immigration, and I think the support actually recedes a bit, and for many people, finding solace in alcohol maybe might be in that isolation, with nobody telling them to stop, etc., may have something to do with it.
In that case, what would be the difference with the second generation then, that are becoming more and more dependent on drug use or alcohol abuse?
So I think the second generation it does not have those challenges of the language. They don't have the that much of a challenge in terms of fitting in, because they've been there, done that. I think out here, the in the second generation there is more, it is more to do with mental health, trauma, broken families, um, things like that, and then again peer pressure. I think culturally still, even if you go into the second generation, the 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 whole linkage of alcohol and its association with maleness is still maintained, uh, and for that reason I think maybe the use continues in that second generation.
Do you have parents that come to you as well saying that their children are addicted and asking for support for their children and not knowing how to support them?
Again, more specific to the South Asian community.
Yes, so yes, we do have parents, who sometimes present to a drug and alcohol service. Sometimes the mother and father will actually walk into a drug and alcohol service with their son, their 25, 30-year-old son, and they'll insist to be in the same room, and because they'll feel that the other person may not be completely truthful of their problem, and then they will actually recount the tens of thousands of pounds that they have spent in detox centers, where they were promised that after this detox this person will become better. What is consistently lacking, however, is a ongoing engagement in terms of working with a key worker, goal setting, work around mental health before going through a detox. Anybody can actually buy a detox for 6 or 7 thousand pounds for 7 to 10 days. But if the work has not been done beforehand, the 6 to 6 months or a year amount of work that needs to happen before that detox will happen, well, the relapse simply occurs and money is wasted. So the families take on a financial hit along with an emotional hit in addiction cases, and the South Asian family, being more quite cohesive, will actually sometimes present to a clinician. Uh, uh, the mother and father, along with their son or daughter, will present, and they will actually tell you of the issues that they have faced. And they will explore all kinds of things like trauma, shame, stigma. All those things would be spoken about in that appointment. Uh,
But do you think that, especially because again we're looking at things, subjects with a stigma, how much do the parents, as they're standing in the room, take on? Because sometimes, as a community, as a South Asian community, we are very good at saying, "Look, this is the problem, ABC," but we don't know the cause of it, or we're not taking that cause on and moving forward with that before we look at, I suppose, going into the detox centers, for example.
I think a lot of these initial consultations, where I think it's always a first experience for many of these South Asian parents when they actually walk into an addiction service and actually speak to an addiction clinician, and it sort of transforms their perspective, that they were looking at the problem, but they were probably looking at it in a much more simpler way. And probably that the work that is needed in managing the problem is more of a longer, uh, there's a more amount of work, there's a longer amount of work needed, both in terms of duration as well as in terms of effort, in terms of the person who's suffering. um, I think that is the awareness, that there isn't a well-paid shortcut business class zap me to recovery land type seat here. It's going to recovery will come, but it'll come with hard work.
Do you know what's so interesting about about this episode? You've sort of highlighted the fact that the reason they've started the alcohol is because there's problems before. The treatment, you can go in for a treatment, but there's work to be done before.
Yes,
It's such a long process once you get into this addiction cycle,
yes,
and everyone's involved. As we
yes.
as we come to the end of this podcast, what advice would you give the South Asian, and I suppose maybe more specifically to the Punjabi community as well, about addiction, and firstly trying to stay away from getting addicted, but those that are, what can they do?
So I would say that the Punjabi community is one of the leading communities in the UK that has assimilated very well with the local population. We are successful in every possible way, but that success has come with its own perils, and I think one of these perils is addictions. Uh, the advice is to not treat it as a taboo subject, but to talk openly about it, discuss it openly in the Punjabi media, in the Punjabi TV channels, even in the Punjabi paper that shows up at the Gurdwara. Uh, Talk about it in the temples. Probably run self-help groups there. Make it a part of your festivals. That okay, this is a problem here too. It is an unspoken truth. A stigma that is not being talked about. Uh, and once we start talking about it and bringing it out in daylight, then we can start dealing with the problem. Come up with strategies about how we can actually help these families, because these are family illnesses. These are these families that are suffering. So yeah, so I think yeah, so my advice would be to talk openly about it, to not push it under the carpet, to seek help early, to be a part of a friends and family support program if you have a significant other who's actually suffering with addiction but refuses to seek help for it. um, Probably go into counseling yourself if you are living with somebody who actually has problems like this. Similarly, if you experience domestic violence, which is again all the more common, You can again go to a domestic violence charity and actually discuss these issues. You can actually refuse to actually have a referral being made, but at least seek the support uh, which is out there. Start talking to people, and hopefully good things will come by and changes will come.
Lovely. Thank you so much for your time, Dr. Ram Arora. It's been very eye-opening. Obviously, we started this subject in regards to alcohol abuse previously a few weeks ago, but it's really great to hear the other side and what you see in your patients, and the fact that this isn't just a short thing. It's not just a one-hit thing. It's gonna turn into your life, which is depressing to say that in itself. So
Yeah.
thank you very much for your time today.
It's been a pleasure.
That's goodbye from me.
And goodbye from me.
Follow us on Instagram and Facebook, changing_suits, and subscribe so you never miss an episode.